My name is Tatiana Milman. I'm an ophthalmic pathologist. Today I will discuss pathology of ocular trauma and wound repair. I have no relevant financial relationships with commercial interests. In this talk, I will first discuss pathology of selected eye injuries. I will then touch upon pathology of some wound-related complications, and I will finish by briefly describing pathology of immune-mediated responses to ocular trauma. Eye injuries are divided into two major groups. Open globe injuries result in a full-thickness eye wall wound. Conversely, closed globe injuries do not result in a full-thickness eye wall defect. In addition, the spectrum of pathologic findings will differ depending on the mechanism of injury, which falls into two major categories: penetrating and perforating trauma to the eye with a sharp object, and trauma to the eye with a blunt object. By definition, penetrating injuries involve partial thickness defect in a structure, while perforating injuries involve a full thickness defect in a structure. In this particular example, there is an evident full thickness corneal laceration, also called corneal perforation. And depending on where the tip of this foreign body is, there is either a penetrating or perforating injury to the lens, and either a penetrating or perforating injury to the eyeball itself. In contrast, blunt trauma induces deformation of the eyeball, leading to traction on ocular tissues with resultant diverse pathologic manifestations. For example, severe deformation of the eye wall will induce eye wall rupture, leading to an open globe injury. In an otherwise normal eye, this typically occurs at the thinnest points of the eye wall, namely posterior to the insertion of rectus muscles, at the corneoscleral limbus, and at the center of the cornea. This photograph of the enucleated eye following blunt trauma demonstrates rupture posterior to the rectus muscle insertion, with resultant expulsive choroidal hemorrhage and incarceration of intraocular contents, namely uvea and retina, in the wound. Blunt trauma can indent the cornea and displace the iris posteriorly. Apposition of the iris to the lens creates a closed system with resultant propagation of the aqueous currents peripherally towards the anterior chamber angle, with resultant dissection of anterior chamber angle tissues. This leads to a range of pathologic findings, such as disinsertion of the ciliary body from its attachment at the scleral spur, also known as cyclodialysis, which you can appreciate in this photograph. Corresponding histopathologic findings of the same eye demonstrate scleral rupture posterior to rectus muscle insertion with expulsive suprachoroidal hemorrhage and disinsertion of ciliary body from its attachment at the scleral spur, or cyclodialysis. In a similar mechanism, the iris can become disinserted from its attachment at the iris root, a condition which is known as iridodialysis. This patient presented with hyphema, a clue to the anterior chamber angle injury in the region of the major arterial circle of iris and ciliary body. As the blood cleared, we can appreciate iridodialysis and traumatic cataract formation. Analogously, blunt trauma to the anterior segment can result in angle recession, defined as the tear in the anterior face of the ciliary body between the muscle fibers. In this photomicrograph, we can appreciate posterior displacement of the ciliary body, accompanied by the deepening of the anterior chamber angle on the left side, as compared to the anterior chamber angle on the right side. Note, however, that the ciliary body remains attached to its insertion at the scleral spur. In addition, we can appreciate suprachoroidal and vitreous hemorrhages. Retinal detachment is also present. higher power photomicrograph highlights a tear between the ciliary body muscle fibers, and in an even higher magnification photomicrograph, you can appreciate an additional tear in the trabecular meshwork itself. And this is one of the findings that can potentially predispose an eye to a later development of angle recession glaucoma. Blunt trauma-induced traction on posterior segment tissues can also lead to significant and varied pathologic manifestations, a classic example of which is choroidal rupture, which you can see in this photograph. Now we will move to a second part of this presentation, in which we will discuss wound-related complications. Several sight-threatening complications can be caused by a poorly opposed wound. For example, this photograph illustrates incarceration of intraocular tissues in the wound, which resulted in vitreoretinal traction and secondary retinal detachment. Microscopically, we can appreciate a corneal wound which healed with a vascularized scar. The iris and vascularized vitreous are incarcerated in the wound, causing traction on more posteriorly situated intraocular tissues. Poorly opposed wound can provide a passageway for infectious agents into the eye, as illustrated by this example of an acute exogenous endophthalmitis. We can see a perforating wound in the wall of the eye with extensive suppurative intraocular inflammation. And microscopy of the same eye demonstrates perforating wound to the cornea with incarcerated, acutely inflamed vitreous. Higher magnification photomicrograph highlights poorly opposed wound with incarceration of acutely inflamed vitreous. And on another slide, we can appreciate multiple bacilli, which are obvious both on H&E stained and Gram stained preparations. And these organisms were identified by culture as Bacillus cereus. Besides the organisms, surface epithelium can enter the eye through a poorly opposed wound and can grow in a multi-layered fashion on the posterior surface of the cornea, along the anterior chamber angle structures, and on the surface of the iris, as well as more posterior tissues, causing significant visual complications. Similarly, fibrous tissue can grow through a poorly opposed wound into the anterior chamber angle. Trauma to posterior segment tissues can also lead to vision-threatening complications. For example, in this eye, choroidal rupture resulted in exuberant choroidal neovascular membrane formation. A higher magnification of an enucleated eye demonstrates detached retina with organizing subretinal hemorrhage, and a vascular mass extends from the choroid into subretinal space through a break in Bruch's membrane. Microscopy similarly demonstrates folded retinal pigment epithelial breaks and a fibrovascular and inflammatory membrane which extends from the choroid into subretinal space. Our immune system can react exuberantly to eye trauma, and I will very briefly discuss classic pathology of key trauma-induced immune-mediated conditions. Symptomatic ophthalmia is a classic, rare but feared type 4 immune-mediated delayed hypersensitivity response to eye trauma. Traditionally, sympathetic ophthalmia has been described to present as a bilateral granulomatous choroiditis occurring about 1 year following injury, typically a non-surgical injury with uveal prolapse. However, sympathetic ophthalmia can occur as early as 5 days and as late as 50 years following trauma, and can be iatrogenically induced, which is becoming more frequently recognized. This patient developed sympathetic ophthalmia following multiple surgical procedures, including cycloablative procedures and panretinal laser photocoagulation. Gross pathology demonstrates diffuse infiltrate and diffuse thickening of the uveal tract, with focal subretinal pigment epithelial white nodules and adjacent laser scars. Photomicrograph demonstrates choroiditis and sub-RPE nodules corresponding to the gross image, which you just saw. Note that the inflammation is present in the scleral emissarial canals, highlighting the point that evisceration does not protect from sympathetic ophthalmia. On higher magnification photomicrograph, we can appreciate diffuse granulomatous choroiditis, also known as salt and pepper choroiditis, and sub-RPE granulomas, known as Dallin-Fuchs nodules. Phacoantigenic endophthalmitis is a type 3 immune-mediated hypersensitivity response, an immune complex hypersensitivity reaction to lens antigens, which typically occurs following traumatic rupture of lens capsule. This gross photograph highlights a white infiltrate centered around the lens and in the lens, suggestive of infiltration by inflammatory cells of the lens substance. In this PAS stained preparation, we can see a break in lens capsule associated with an inflammatory response. And on a higher magnification photomicrograph, we can appreciate a characteristic zonal granulomatous inflammation with an inner zone of neutrophils infiltrating lens fibers, the middle zone of granulomatous inflammatory infiltrate, namely epithelial histiocytes and giant cells, and an outer zone of a chronic non-granulomatous inflammation, namely lymphocytes, plasma cells, and granulation tissue. I would like to conclude with a few key points. It is important to remember that blunt trauma can induce both open and closed globe injuries with a range of pathologic manifestations related to traction on intraocular tissues. Second, open globe injuries can result in a variety of wound-related complications ranging from infections to epithelial downgrowth. And last, although rare, we should always consider immune-mediated responses in patients with potential history of eye trauma. Thank you for your attention.